Thank you, Dr. VEITHs, for the invitation. No disclosure. So endovascular therapy for patients with connective tissue disorder remains controversial. These are often young patients with poor tissue quality and ongoing dilatation, and there is limited evidence and unknown knowledge of the durability of endovascular repair in this group. However, we have recent development in the endovascular toolbox, which allows us to treat more completely and also more disease-specific. And this justifies a reevaluation. This is a Marfan patient, 33 years old, with a post-type A dissection thoracoabdominal aneurysm with perfusion of the renal visuals from both lumens, treated with a branched endovascular device with proximal landing zone in a surgical graft with good long-term outcome. Another Marfan patient, syndrome patients with large patch aneurysm after previous type 2 thoracoabdominal open repair, treated with the fenestrated branch combination EVAR with proximal and distal landing zone in surgical graft. This also includes fenestration for large intercostal artery. Another Marfan patient with the post-type A dissection, arch and descending aneurysm, treated with an arch branch stent graft, TIVA down to the celiac artery and a candy plug to occlude the false lumen with good thrombosis and good remodeling of the thoracic aorta. A Marfan patient with post-type A dissection, arch descending aneurysm, treated with arch branch device and a dissection-specific stent graft with very low distal radial force, also with good remodeling of the aorta over time. Finally, a young patient with vascular Ehlers-Danlos syndrome presented with acute type B dissection with distal malperfusion, treated with a dissection, Cook dissection stent graft. We had severe problem with the access, and then we realized that there was something odd with him. We also had to abandon a carotid subclavian bypass attempt due to the tissue quality. So he developed arm ischemia, but survived now over 5 years. He also ruptured his colon afterwards, which is typical for these patients. He's put on celiprolol treatment for life. So to address this, we did this Multicenter VEITHs registry study. 18 aortic centers worldwide contributed. In total, more than 200 patients, some of them with unknown genetics. So I will focus on the proven cases, mostly Marfan patients, but also some Loeys-Dietz syndrome and vascular Ehlers-Danlos. You see they are about 50 years old. The vascular Ehlers-Danlos a bit younger. In most patients, they presented with an acute dissection, and almost half of them complicated with rupture or ischemia. In the Ehlers-Danlos syndrome patients, even more complicated with rupture and more aneurysm. Most patients with Marfan and Loeys-Dietz had prior aortic surgery proximally, not so in the vascular Ehlers-Danlos syndrome group. More than half of the devices landed in a proximal surgical graft, and obviously in the vascular Ehlers-Danlos that was not possible all the time. And half of the patients had arch or visual branch involvement in the repair, in the endovascular repair, so these are highly complex procedures. And this is the main outcome, 5 years survival curve. You can see excellent outcome for the Marfan and Loeys-Dietz groups. The vascular Ehlers-Danlos group is doing much worse, not necessarily due to aortic reasons, but generally they are a difficult group. The 30-day outcome, stroke rate 5%, spinal cord ischemia 2%, renal failure 3%. These are excellent outcomes. Over the 5-year period, 54% reinterventions, mostly endovascular, only 8% required open conversion. So in conclusion, EVAR, including redo procedures and complex repairs of the arch and renovisceral aorta in patients with connective tissue disorder, has a low perioperative mortality and morbidity. Mid-term survival is comparable or even better to reports of open repair. It's a high rate of reintervention. Few patients require conversion to open, and in conclusion, an endovascular strategy is a reasonable treatment option in these patients group deemed high risk for open repair. I want to thank the investigators, and the study is ongoing, recruiting more patients with longer follow-up, and new sites are welcome. Thank you.